Thank you very much. And at the outset, I'd like to thank the Anuradhapura Medical Association for inviting me to talk to you on evaluation of headache. And a very good morning to you all. Some of you must be having some headaches after yesterday night's celebration. So quite an apt topic to start on, I should say. Right, okay. It's a very simple sort of topic, and questions will be asked. So I will probably come down and ask a few questions in that particular area. Yeah. So please don't run away. Right. So this is my outline, if you can see it, for this talk. We'll start off with a little bit of epidemiology, and then recognize red flags, how to perform a focus history and examinations with a focus on headache, or the appropriate investigations, outline the management strategies, very, very brief management strategies, and also apply knowledge through real life clinical scenarios. So a little bit about the epidemiology, very simple. Headache is one of the most common pain syndromes that most of you would experience with regards to patients. And approximately half of the global population experience headaches each year. And in primary health care, headache is one of the top 10 reasons for a consultation. And most of the headaches that you would encounter in primary health care would be primary headaches. And that includes tension type headaches, migraine, and very, very, very rarely cluster headaches. And this is the general epidemiology worldwide. We generally experience tension type headaches. I, of course, would dispute this, wouldn't you? Yeah. Because most of our practice as neurologists, we would generally see what would be the commonest type, what Manjula would say, migraine, yes. But this is how it is. And these are world figures. So tension type headache is the number one, and migraine is number two in prevalence when it comes to headaches. Right. We generally classify headaches into primary headaches and secondary headaches. Does anyone know the difference between a primary headache and a secondary headache? We'll ask the neurologist in the audience, because he's right in front of me. Yes? What do you think is a primary headache? What do you think is a secondary headache? Yeah. So secondary headache is there's always a secondary cause. It could be either a direct insult to the brain, or it could be a systemic insult that results in headache, right? And headache has the primary symptom, mind you, right? And these are an exhaustive list of probable causes of secondary headache. And of course, the primary headaches, number 1 and 2, are both migraine and tension type headaches, and cluster comes in a very small proportion or a minority of patients that you would encounter. And very important is around 18% of your headaches, right, or 1 in 5 might have a secondary cause for a headache. And that's very important for you to sort of pick out. So that means 1 in 5 will have a secondary headache. Most of your headaches will be primary headaches. And since tension type headache and migraine are the two most common types of headache, you need to know what their clinical features are. So tension type headache, these patients would have a headache which is generally mild to moderate, right? These patients will not say that they have the worst headache in their lives, right? And generally described as pressing or tightening type of pain, which is generally bilateral, right? If someone says it's a unilateral headache, then you may not be dealing with a tension type headache. and it does not aggravate by routine activities. So they are able to perform their general daily activities of daily living without too much impairment as a result of the headache, right? There's no nausea or vomiting generally, but they may have a little bit of photophobia or they may have phonophobia, but not both together. And then there are, of course, diagnostic subtypes where we've sort of classified them into infrequent, frequent, and chronic, depending on the number of days that they would experience headache, right? So this is the most common primary headache. Of course, Manjula and myself would dispute this because we see more migraines, right? So a little bit about migraines, right? Migraines, like the mnemonic suggests, right? The clinical features are that they are pulsatile. 1 day in duration means that generally it's a spectrum between 4 to 72 hours on average. These patients would have headache, the duration of one episode. Generally unilateral, but can be bilateral, right? Associated with nausea and vomiting, and of course, it has a disabling intensity compared to tension type headache. Now, migraines will disrupt your routine activities. That's very important. So, exacerbated by routine physical activities, you should always ask whether your headaches routinely disrupt your activities, right? And also, photophobia, phonophobia, and aura are often can be features, but do not always look for an aura because it is often seen in the minority. It's seen in approximately 15% of patients with migraine with aura. So that's not very common. Then if you have 4 or more features of this pound features, then there is a high likelihood that you are dealing with a migraine. Then a little bit about cluster headaches, which are basically very rare. Generally seen in less than 1% of your primary headaches. It is very severe, right? They cannot stay in one place. They are always running about. Now this is in contrast to the patients with migraine. Migraine patients often they lay still, whereas patients with cluster headache, they cannot stay still and they are always holding on to the side in which the pain is, right? And often is a side lock headache around the orbit and the temporal region, and they would last between 15 minutes to as long as 3 hours, and can sometimes these episodes can come about more than once per day to a maximum of approximately 8 times per day. And the quintessential or the emphatic or the most characteristic feature are autonomic symptoms, right, which are unilateral, right, and they fall under the trigeminal autonomic cephalgia group of headaches, where you can have tearing, congestion, a bit of hoarseness if it goes on for a long period of time, nasal congestion, sweating, which is unilateral, all of which are autonomic features which are associated with this type of headache. They can be again episodic or chronic, because often the episodic patients would have these bouts of headache lasting from between 6 to 12 weeks, and then they go into a period of remission, right? And then it starts again. So it's very periodic. They might have it once or twice a year, and during that time they will have 6 or 12 weeks of excruciating pain, then all of a sudden no headache, and then it restarts maybe in 6 months or the same time each year. Those are the episodic forms of cluster headache, right? And then of course the chronic forms where there is no remission in between episodes. So if there is no remission of 3 months, between these bouts, then we would generally define them as chronic, right? Secondary headaches. So some of the examples that I've given are examples like subarachnoid hemorrhage, which is generally the most, or patients would say that this is the worst headache in their life, right? It is what we call a thunderclap headache. Does anyone know what a thunderclap headache is? Yes? What's a thunderclap headache? It is where someone is hit by lightning. No? Thunderclap is a headache which is brought on within a minute, right? Where the intensity, the maximal intensity of the headache comes within a minute. And it is an extremely severe type of headache, right? And it's very important for you to get that part of that particular feature in your history. Then, of course, meningitis, if the patient has fever, neck stiffness, and altered mental status, might suggest that the headache is of an infective cause, such as meningitis or encephalitis. Then, of course, early morning headaches, intracranial masses, hemorrhages, and so on and so forth. There's a long list of secondary headaches which I have listed out on this slide. Temporal arteritis, especially if it's a new onset headache over the age of 50. And of course, venous thrombosis headaches again can mimic these thunderclap headaches, which are as a result of subarachnoid hemorrhage, but even venous sinus thrombosis can mimic thunderclap headache as well. Right. So how do we define, or how do we define these red flags which might suggest that this is a secondary cause for a headache? And that's defined by this mnemonic SNOOP. SNOOP. So S stands for systemic symptoms such as fever, weight loss, cancer, or HIV if the patient has that particular history. If there are neurological signs, N stands for neurological signs such as confusion, focal neurological deficit, seizures, and so on and so forth. Onset, if it is again acute, hyperacute in onset. If the patient is older than 50 years of age, or has a pattern change or prior pattern change, or if it is the first ever headache. All these are red flag signs, right, which might suggest that you may be dealing with a secondary headache. Then we have the extended SNOOP 10, right, where N, the extra N stands for neoplasm history, right? And of course, 10 Ps, if the headache is positional, if there's a pattern change, again progressive, precipitated by cough or Valsalva, if there's papilledema, if the headache is associated with pregnancy or puerperium, if there's a painful eye, post-traumatic onset, pathology of the immune system such as immunosuppression, or if the patient is overusing painkillers, all of these may suggest that you may be dealing with a secondary headache. So you need to get a good history, and more history, and that's what's going to for you to be able to differentiate between a primary and a secondary headache. Onset, duration, progression, very important when it comes to the history, location and the quality, if there are any triggers, relievers, and of course the frequency of headache, and the associated symptoms such as nausea, aura, and whether there are systemic symptoms such as fever, and so on and so forth. The medical and drug history is very important. Comorbidities such as cancer or immunosuppression might suggest that this may be a secondary cause of headache. Medication and over-the-counter use, analgesics, certainly, especially opioids, then recent trauma or procedures, and of course, don't forget your physical examination. You need to look out for the vital signs, your general appearance. Neurological examination is very important. You need to look into the eyes, look for your fundoscopic examination, looking for papilledema, and of course the head and neck examination, looking for sinus tenderness, TMJ junction tenderness, and of course temporal area tenderness, looking for temporal arteritis. So when do we decide on imaging? So if a patient presents with headache, most often these patients do not require imaging, right? So for example, if a patient comes to you who has had headache for 18 years, right? And they come and ask, doctor, do I need a scan? Because I've had a headache for 18 years. Would you scan them? Would you scan them? Yes. Again, it's history. But the chances are that you're not going to find anything on your scans. And it becomes an unnecessary investigation and an unnecessary cost, because now we have to also consider cost of healthcare, right? Cost of a scan. So it goes against logic that this patient, if the nature of the headache has not changed, the patient often does not require a scan, and it's a very common scenario that most of us experience in primary healthcare. So it's very important to look for red flag signs, right? And that's where the SNOOP and the SNOOP 10 is very important. And if that comes as positive, then of course you would consider at least a CT if you suspect some form of hemorrhage. Of course, an MRI scan would be ideal when you're considering other causes of secondary headache. Principles of management, right? Lifestyle and non-pharmacological strategies are very important and probably not often focused on when we are evaluating patients and managing these patients. You need to identify and avoid triggers. Very important, especially when it comes to the primary. Now, these are management strategies for primary headaches, right? And sleep, stress, and certain food items and so on and so forth. These are very important triggers, and it is very individual. So you need to find out the triggers of that particular individual and focus on preventive strategies when it comes to lifestyle. Maintaining regular sleep and hydration, very important. Stress management, and of course, physical therapy, acupuncture, and relaxation. All these are various strategies that we could use to treat these patients. Of course, then we have the pharmacological management. Especially, we forget acute therapy. Often we start them on preventive therapy. We forget to treat the acute phase of both migraine as well as tension type headaches. So NSAIDs, acetaminophen, triptans when it comes to migraine, and of course oxygen sometimes can be useful in treating cluster headaches. Preventive treatment such as beta blockers, anticonvulsants, antidepressants. We do not have CGRP inhibitors in this country, but this is now a go-to medication in the West. You need to make sure that they avoid opioids and barbiturates. Any reason why? The neurologist in the front row. High chance of medication overuse. So and it's very common. We do not screen for medication overuse. You need to ask if are you taking analgesics for more than 10 days per a month, and if it occurs for more consecutively for 3 months or more, then that there is a higher chance that this patient might have medication overuse headache. So please screen for medication overuse headache. It's very important. And of course, so that's why we generally avoid opioids and barbiturates. Right. So this is a case vignette. It's a 45-year-old woman who presents to your clinic with sudden onset severe headache, described as the worst of her life. The pain reached maximum intensity within 1 minute, and is diffuse. She feels nausea and has photophobia. Blood pressures are 150/95, and she is slightly lethargic. What red flags are present in this particular clinical scenario? Yes? It's good for you to interact, otherwise I'll fall asleep. Yeah, the onset. Yeah. What else? So onset within 1 minute, right? Which suggests that this is a hyperacute headache, right? If it is a hyperacute headache, we consider the number one cause it to be the headache to be due to a vascular cause. It has to be a vascular cause, and of which I think you might have to consider what is the diagnosis in this patient. What immediate investigation would you? So would you image this patient? Yes, yes, right? Because your Snoop mnemonic, you fulfill criteria, right? And it's a hyperacute headache, brought on within a minute, and defined as a thunderclap headache. And you would go for what kind of imaging would you consider? Sounds like? Yeah? What kind of imaging would you consider? Yes? Sorry? A non-contrast CT brain, right? Why non-contrast CT brain and not an MRI? We are all so happy to do MRIs in this country. Yes? Why? We are looking for blood, no? And CT would be accessible, can be done within minutes, right? And you'll be able to make a diagnosis. So CT would be your number one form of imaging. And what is your leading diagnosis? Obviously, subarachnoid hemorrhage. So the red flags are sudden onset thunderclap headache. Of course, there was associated nausea, photophobia with blood pressures being high, right? And investigation would be a CT to rule out a subarachnoid hemorrhage. And if the CT is negative, which can be seen in approximately less than 10% of patients with subarachnoid hemorrhage, and if the patient still has, the history is very suggestive of thunderclap headache, what would you do next? You would do a lumbar puncture to look for xanthochromia in the CSF. Right. A 26-year-old woman reports recurring unilateral throbbing headache lasting 24 to 48 hours, accompanied by nausea, vomiting, photophobia, and phonophobia. Physical activity exacerbates the pain, and she feels better resting in a dark room. There is no fever or neurological deficit. What type of headache does this represent? Primary or secondary? It is a primary headache. Why? None of your Snoop criteria fulfill in the history, right? And then which criteria from the Pound mnemonic does she meet? If it is a migraine that you're suspecting, almost All, right? 4 or more. Do you need to order imaging? No, because it is a migraine, right? So, I hope you get my gist. The last case, and I'll stop. 72-year-old man reports a new temporal headache with scalp tenderness, notices jaw pain when chewing, and occasionally blurs vision in one eye, feels fatigued, and has lost weight. Which diagnosis would you suspect in this patient? Yeah? Sorry? Giant cell arteritis, yes. So, whatever the diagnosis, what I'm trying to say is, what is the Snoop criteria that is fulfilled in this patient? It is a new onset headache after the age of 50 years, right? And after the age of 50 years, and if it's a new onset headache, it is unlikely that you are dealing with a primary headache. So I'll stop there. So this was giant cell arteritis. You need to order ESR, CRP, and of course an ultrasound or a Doppler of the temporal artery or a biopsy, depending on your facilities. And of course, do not wait for the results of the biopsy. You need to start them on steroids. Right. Okay. So key take-home message are most headaches are primary and benign, right, and often are tension, migraine, or cluster. Always screen for red flags, right? The Snoop and Snoop 10 would be very valuable in your screening. Thorough history and examination underpins the diagnosis, right? And imaging is reserved for high-risk presentations. Managing primary headaches with combination of lifestyle, acute and preventive therapies while avoiding medication overuse is extremely important, and early recognition of secondary headache and urgent investigation can save lives. So I'll stop there. Thank you very much for your attention.